All right, welcome back. Looks like everybody is logged in here. Can you guys hear me okay? Good, thank you, thank you, thank you. Okay, so can you see the screen okay? Yes, ESD. Okay, yeah, all right, good. All right, so what I'm going to do is I'm going to start the recording here. And you guys did get the practical sheets, right? Good, okay, so this way you can take notes. So what I'm asking you to do is, if we look at the computer here, is to pick the the brachial plexus, the sim. Basically, I made this protocol up for a simulation. So we're going to pull that over. I'm going to go ahead and choose my appropriate coil here. So what I'm going to do is go to my coil selection, and there should be an NV head in here. Here we go, sense NV head. What that stands for is the neurovascular coil, okay? And if you look on it here, what all of this means is they're letters, but it just means I'm doing the head, the neck, anterior coil, and posterior coil. So that's what HNACPC means. If I only wanted to turn on the neck coil and the anterior and posterior, I don't have to turn on the head coil, but we're going to just turn on all of them here. Proceed and start. Okay, and here is my 3-plane pilot here. Let me try to kind of lighten them up here so maybe you guys can see these well. Okay, so we can do a reference scan. We're just going to go ahead and line it all across here. Proceed and start. And the very first thing, so number 4, that I'm going to have you set up for is a coronal T1 of the brachial plexus. So I'm going to go ahead and open it. And we're going to assume the coil selection is still going to be the same, okay? So it says choose appropriate coil. So if you want, you can go ahead and go back to your NV16, which stands for the neurovascular coil. And then here's where you need to tell me what kind of field of view do you want. So I'm going to slide this up. And I already know, as I page through here, I can see, I'm going to do a coronal, so I'm looking at my coronal viewport. I can see at the very top, and you can probably see it better once you get here in the lab, but I can see where C2 is because I can see my dens, okay? So I want to make sure that I can see the dens, and the very bottom here, I don't need that much coverage below. So I'm going to change my field of view in the head to foot direction, and maybe let's go to like a 200, and I'm going to bring that back up. So what you'll notice is the very top of my field of view, in the head direction, I want to make sure I can see the C2 so I can count. And I'm going to go ahead and just get right below where the pretty much cords, or not cords, but the branches of that brachial plexus will be, okay? Now right to left, I can bring my right to left in. Probably even, let's try a 300. 300 by 200 is what I have. So right here, I still can see the branches of my brachial plexus. Your book will tell you that you can like stop, I think, right at this coracoid, which would be like right here. But if you get right into this humeral head, you will be fine. So field of view that I have set is right to left 300 and foot to head 200. Now, that's going to be dependent on your patient, right? So again, you definitely want to be looking at your anatomy coverage versus just memorizing numbers. So our slice thickness that we're going to use, and I'm going to pull up the brachial plexus here, is on page, I think it was 270 in our book. And for their coronals, they have a 4 millimeter thickness at a 0.5 gap. So what we can do is do a 4 millimeter at a user-defined 0.5. Even if you would put default, that's a 0.4. I am good with that. Okay. So now I want to go ahead and bring my slices into my image. And I'm going to go over to my sagittal, because what we want to do is we want to angle and we want to be parallel to the spine. So I'm just going to be parallel to the spine like that. Okay? And our coverage then should be from about the posterior, the spinous process to the anterior wall. So I can probably take a couple slices off. And I have 21 slices here. I have from this spinous process to the anterior wall. In your book, it'll tell you from the anterior wall through the posterior spinal cord. So there then, that would be about right here, posterior spinal cord to the anterior wall. Because notice that your brachial plexus will be coming out right in the center here from these nerve roots out, right? So whether you get the spinous process to the anterior wall or posterior spinal cord to the anterior wall, either one will be okay with me. So if I stick with this here, I have 18 slices, okay? And on my sagittal, as I page through, notice that like this very last slice, I'm into the, right, your clavicles here, your sternoclavicular area. And so I should be way through where that brachial plexus is going to enter. If you feel like you want to move it up a little bit and maybe even add a couple slices to be sure, that is fine. So here you would have then, you got your spinous processes back posteriorly, you're through this anterior wall, and right here is where your sternal notch is at. Okay, so I have my field of view that I like. I have my slice positioning and my slice thickness that I like. The voxel size that you're going to pick, well, I have a 0.8. And because these are relatively, you know, smaller nerves that we're going to look at, let's go ahead and do a 0.8 in both directions. So like a 0.8 by a 0.8, which will give me a square voxel. Okay, now could you leave it at 1? You could. There would be nothing wrong with that. I'm just giving you things to think about as you are setting up for this particular protocol here. My NSA that I have chosen is 4. I have 3 minutes right now, and I'm going to go ahead and make this T1 weighted. So I'm going to go to my contrast, and I have a TR of 633, and if I look at my TR, I have it on range. If I go to shortest TR, the shortest TR is 633. So I can't go any lower than that, and it's going to have to take me 2 packages. Now, my TE I have at 14. That would give me good T2 weighting, 633 TR, a TE of 14. But my turbo factor here is kind of high for a T1. I'm going to bring that down to 4. Let's see if it'll allow me here. And the reason that it's, let's go back to, it might be because of my fold over here. So I'm going to go back to 7. I'm going to go look at my fold over. This is a coronal, so I have either right to left or head to foot. And definitely I don't want head to foot because I don't want any of this heart motion coming up into my brachial plexus images. So I'm going to have to go right to left, and I'm going to have to make sure that fold over is turned on, and it is turned on here. So let me now go back to, it's not allowing, oh, it was the spacing, I'm sorry, that's what I was changing. So I'm going to change my turbo factor to 4. It was at 7, I don't want it at 7, that's a little high for a T1 weighted. I'm going to take my number of 180-degree trains and bring it down to 4. So that gives me a time of 3 minutes and 25 seconds. And I have a 4 necks, and that's actually pretty good. So I like this. It's 3.5 minutes. I'm going to proceed and start. Now, first of all, let's go back here. Is fat suppression needed? Well, I'm asking you to do a coronal T1, so no. State your phase direction. Well, we talked about we want right to left, and we got to make sure then that fold over is on. And the reason that I want right to left is because I want the heart motion to go this way below where my slices were positioned, and not head to foot where it's going to interfere possibly into where my brachial plexus is going to travel through. Okay, so I liked that. Proceed and start. So right now I have a better T1 weighted image. And the T1 weighted image, and you can write this down, the series is scan 5. So I'm going to replace my coronal localizer with my T1 weighted image, and which is here. Okay? And this actually looks pretty good. Because as I page through my slices, notice I'm just into where my humeral head is located. And then if I look at my spine, I am right at the tip of where my dens is. So I can see that this is your C2 vertebral body. And if I go 2, 3, 4, right here would be 5. So I know right here at this, starting at this nerve root, is where the start of my brachial plexus will lie. So number 5 is telling me to set up a stir coronal of the brachial plexus. So I'm going to set this up identical to how my coronal T1 was. So I want to make sure that I am right to left was 300. Foot to head was 200. I made sure that I was right at where my C2 is located. Okay, I had a 4 necks at a default. I have fold over turned on, and it's in the foot to head. I don't want foot to head. I want it right to left direction. So now I got to change this. Foot to head at 200 and right to left at 300. There we go. I'm going to bring this down. I think it was 21 slices. And I'm going to angle it with my spine. And kind of look and say, I'm going to go ahead and make sure the very first slice is at that spinous process. I'm all the way over to the anterior neck wall. So I like, this looks pretty much identical to what I set my coronal T1 up with. My voxel size is 0.9 here by 1, and this is going to be a stir, so right off the bat I know that this is going to be more of a grainier looking picture because I'm eliminating fat out of my image here, right? So my voxel size then, if I would even just do a 0.9 by a 0.9, that would be okay, even though my matrix isn't as high definition or the same resolution as my T1 coronal. You have to think, well, you might have to go ahead and bring your matrix, make your numbers a little smaller, the matrix numbers, make your voxel size a little bigger, only because you might need signal. You're taking the fat signal out, so sometimes with stir imaging, you have to think about, but I need signal back in my image, okay? So therefore, I'm going to go to my contrast page. I have a TR of 2202, and here it has a range of 1500 to 25. Well, I really want my minimum to be about that 25, and then I can go up to what, maybe 6,000? And notice then my TR will change, whereas I can do a TR of 4,037, it drops it to 2 packages. I want to go ahead and do a TE. Now you can do 60, or if you drop that TE down a little bit, let's say you need a little bit of signal again. If I drop my TE from 60 to 50, that's going to add a little bit more signal in my pictures. My inversion delay, I'm going to want that around that 140 or 150, that range. It's a 5-minute scan. I'm going to go up to my turbo factor here. And normally for a stir, I think we're around in that 14, 15 range. Okay. And it's 6.5 minutes. I'm going to go to my motion and I'm going to turn my NSA down to 2. I'm going to do a 2 next for this. And what this does, it'll give me a scan duration of 4 minutes and 28 seconds. Okay, and I actually like that. I think for a stir weighted image, that will be fine. So then I'm going to proceed and start. Okay. Number 6 is to set up an axial T2 fat sac of the affected side. So this is where you will need then to ask your patient, or from their history, and let's say your patient says they're having right upper extremity weakness in that arm or in that limb, right? So right off the bat, I'm going to page through my coronals here. I can also replace, oh, I didn't do any axials yet, so nope, I cannot replace this axial yet. So I'm going to page through these coronals, and right off the bat, I can see on the right side the right subclavian, and I can see on the left side the left subclavian. And if you look right above that, your subclavian arteries here are going to be darker, and you see this kind of a grayish lines right above that. That is your brachial plexus. Okay, and right above the subclavian here is where we're in more of the trunks, and then into the cords, and then down here we're into the branches. And we can see them on both sides. Okay, so now I'm going to do an axial T2 fat sac. So I'm going to pull that up. if I look at my book for these axials, they do a 4 millimeter thickness at a 0 gap. So I'm going to go to my geometry and I'm going to do a 4 thickness at a 0 gap. Now, my slice thickness then, or my field of view is going to be dependent on my coverage that I need, right? So I'm going to turn off my volume box so you don't see that. I'm even going to turn off my slices. We're on number 6, Chelsea. To set up an axial T2 fat set of the affected side. Does that make sense? Use the same steps. Oh, got it. Well, these are just steps. I'm sorry. These are just to use the same steps. So you can go through A, B, C, D. It doesn't necessarily mean you're setting it up exactly the same way. So I'm going to turn off my slices just so I can get my angle. So if I look at where this brachial plexus is coming down off of, and again, I can page through, and I know that up here is C2, and then C3, and then start of C4. And I also then can page through where I see my brachial plexus, the cords, and then even in the division and into the cords right above that subclavian here. I'm going to angle and do an oblique angle of this brachial plexus. Some places might do a straight axial, others will do an oblique. So notice I do not need these slices all the way down to my aortic arch here. So I'm going to take probably a good 15 slices off for now and then move this up. Okay? My field of view that I'm picking, so only patients, we're only doing the patient's affected side. So you have to think about this in your practical. They might have left upper extremity weakness. So then you're going to do this to the left side. Okay. So the field of view then that I am going to cover, I want to make sure that if I bring this straight down, my field of view box is going to be here in my axial plane here, right? So therefore, I can bring my field of view right to left. I can bring that down a little bit. Maybe let's go to a 180. Okay? But when I angle this along with my brachial plexus, and I'm going to use that center line here to get me my angle, what I'm going to be looking for is that you do not cut off the root of C5. So let's now page through. I'm at C2 here. Here's C3, 4, and 5. So this root should be coming off right here. So I have probably a good 6 slices above that, and I like that. I'm not cutting off that area. If you would bring the number of slices down to 22, well, there's a good chance that that would be good too. Okay, but that's what I'm going to be looking for. Then we can page down where we can see that brachial plexus better. Okay. And notice that I actually have all the way through where we're going to get into the branches, which are about right in this area here. Okay, so I like how this is set up. I'm covering, I at least have the roots, the C5 root, and I'm all the way through the T1 root. So this will give me a nice axial slice right through where this brachial plexus is. And as I page through, again, I know where it's at because I can see, let me go ahead and page through where I can see that subclavian right there. Here's my subclavian. I can see part of this brachial plexus coming down, and it travels alongside your subclavian artery. On the left side, it's going to come down and travel just right above this here. And you can even see there's kind of some of these strings. Those are your nerves. That goes down into that axilla area. Okay, now if you want, you could even on your sagittal slice, you could kind of angle it with your spine as well. So I have that set up. I like my slices. I have 4 at 0 gap. Now my phase direction, I can either pick right to left or A to P. And because this is really only of the affected side, I don't want any part of this right side, you know, even though maybe the carotid's coming up here, going across. So A to P would probably be best to pick. By going A to P, I really don't need fold over. So I can turn that off. If by chance you picked right to left, then definitely you're going to need fold over. Okay, so now let's go to my contrast, or let's first look at your voxels. My voxel size is 1 at 1.2, and you know what, I kind of like to have that 0.8 or 0.9 here. And I personally like some square voxels, but you can do a 0.8 by 0.9. That is okay as well. Okay, so now I'm going to go to my contrast, and I need it to be T2 weighted. So I need to make sure then that my TR, I'm going to go to range, I need to make sure it's above 2,000. And the maximum, I can put maybe 6,000 here. And what that's telling me then is with this TR, I can get all of these slices in one package, and the actual TR is 4,823. But let's go to my TE. That might adjust after I change my TE to be around 100, because I want this to be heavily T2 weighted. If I go up to my turbo factor at 21, well, we're in that range. I like that. So now I have a actual TR of 4,823, an actual TE of 100. I can get that all in one package. It's going to give me good T2 weighting. If I go down to my fat suppression, well, this is actually a T2 spur. You know, a lot of times we're doing T2 spares, but we can do a T2 spur. And what this then allows us to do, instead of changing your spare TR, remember we have to do 1/3 of the spare TR to get full fat sat. If I do a strong pulse, then I will get complete fat sat. If I do a medium pulse, I will get partial fat sat. And if I do a weak pulse, that means I'm getting more fat into my image. So I'm going to let it as a strong pulse, because I want to eliminate as much fat in this as I can. What did you angle the coronal with? This coronal here, I'm angling it with the divisions in the chords of the brachial plexus. I don't necessarily want to angle it with the roots, because that would be coming out at this direction here. So I'm going to kind of angle it more with where the divisions and the chords would lie. So kind of angling it with your subclavian. You're welcome. So I have 3 minutes and 17 seconds. I'm going to go to my motion. I have 4 necks, and that's great. So it's only 3 minutes and 17 seconds. But remember, this is a T2 Fat Sac, so I got to turn on my volume box and position that over the area that I'm going to be scanning here. Cover A to P there, and that looks good there. So it's 3 minutes and 17 seconds. You can click proceed and start. The sagittal T2 of the affected side, okay, I'm going to again go back and I'm going to do a 4 millimeter because our book likes to use the 4 millimeters for brachial plexus. I'm going to go to a 0 gap. If you do a user or default at a 0.4, that's okay. So now what I'm going to do is set up for a sagittal. So if I go over to my field of view box here, I can go ahead and probably change head to foot because I don't need all the way down into the lower part of the chest here. So head to foot, I'm going to bring that to 200. Okay. Your A to P, if I look over here, I can bring down my anterior a little bit if I want to. I actually can bring down to 140, but you have to be careful that by doing this, you're going to have now this part of the mouth wrap in if you choose your face to go A to P, which is what we want. Because if I choose foot to head, I'm going to have this heart motion going up into my images, and I don't want that. I want to keep the heart motion, the flow going this way. Okay, let me change where that arrow's at there. So I'm going to go ahead and include again that top of C2 just so I can count. And I have 2, 3, 4, 5, 6. What is that? 2, 3, 4, 5, 6, 7, 1, 2, 3. I have plenty down. Oh, yes, you can replace. Very good. Thank you. We can replace that axial with this one here. And they didn't do a T2 axial fat sac. This is actually a Thrive. It's an axial Thrive is what this case was scanned in. It's a 3D is what they did. But yeah, you can kind of page through here. I know that if I turn off my slices here, I know that my brachial plexus is going to lie about right here in the middle here. Okay. Going back to my field of view though, I have a field of view, foot to head of 200, A to P of 139. I'm going to make sure I have my fold over direction, A to P, and I do need fold over suppression turned on. Okay. So now let's go to my coverage of slices, or how many slices I'm going to take. I don't need 45. I'm going to bring that down to, let's say, I'm going to need more than 25. Let's go to maybe 35. And some places, if you do a straight axial, then you'll probably do straight sagittals. But since we angled, remember we angled this way. We angled this way for, oh, let me make sure you guys can see it. We angled this way for our axials. I want to now be 90 degrees to that. So I'm going to angle this way for my sagittals. Okay? So basically I'm now perpendicular to the chords and the divisions here, which is right above my subclavian. And then I'm just going to page through again and count, because I want to make sure I get the roots of my brachial plexus. This is C2. So I have C2, C3. Here is C4. I am right, remember, right below C4 is where that C5 nerve root comes out. So I'm going to just move it over a hair, because I want to make sure I get these roots. And then if you page through and you feel like you need a couple more slices to get more of the branches down here, then let's just add a couple slices. So I'm going to add 3 and go to 38. So again, I can go ahead and page through. I'm easily into where the roots of C5 is, and I'm even into the humeral head here, so I should be able to cover then all of the branches from the brachial plexus. And you can even see there's, you know, like these little fingers here. And many times you'll actually be able to see off of your coronal stir images an abnormality. So if you see that there is something abnormal showing up, then again, make sure that you would cover that area in particular. So I like how my slices are positioned here. I'm going to just kind of move it down. There we go. Right like that. So this is a straight sagittal T2, so I don't have to worry about fat sac here. Now I just need to make sure that I have T2 weighting. I have 3,500 TR at a TE of 80, and that looks good. It's giving me 2 packages, and if you even bring your maximum range up here, let's see if that changes. Nope, it's still gonna do it in 2 packages here. My TE's 80, that is a T2 weighted. If you want to make it a little heavily T2, let's see here. It's not allowing you to go to 100. It's allowing 84 is what it's allowing you as the max to go. But that's probably because of your TSE factor of 12. But for T2s, remember, we can go up to like a 22, which will allow me to get my 100. Again, some of these, you know, as you're playing with parameters, you have to think, well, why is it only giving me up to 84? And that's because with a TR or with a TE of 84, it says we can only get a certain amount of trains. So that's kind of why sometimes you have to change one factor or parameter in order to get the other parameter the way you want it. So notice here that my time is only a minute and 17 seconds. I can go to motion, and boy, I can probably bring it up to 4 necks. It gives me 2.5 minutes, and that'll be a good T2 weighted image for you. As long as you have a good coil working for you, working in your favor here. So that is all that we need then for number 7. And start. Number 8, I'm asking you to pull over a T2 axial fat sac, because this protocol that we just scanned was basically a brachial plexus protocol. But we're going to now kind of switch gears and do a soft tissue neck. And I'm only going to have you position one series of the soft tissue neck. Okay, and what I'm telling you is that this patient has a mass in the larynx. Okay, so I'm going to go ahead and go to my soft tissue neck parameters. I'm going to do a T2 axial. I'm going to pull that over, but I'm going to make sure I add fat sac to it. So I'm going to go ahead and open this up. And this is going to be of the larynx. So what I'm going to need to do is cover from the hard palate all the way to the sternal notch. So if I turn off my slices here, and right off the bat, what I first need to kind of do is let's get a good field of view. Because I'm looking at a mass in the larynx, I can probably use a smaller field of view here. Go back up here. Okay, whoa. I already know that my epiglottis is right here. So I know that my larynx is going to be right below it here, okay? I have a field of view. I could probably bring my right to left down. So if I even do a 160 by 160 square, that'll probably give me a good field of view for the larynx here, okay? Now my hard palate, I can see where my hard palate is. It's right above, it's that roof of the mouth, all the way down to my sternal notch here. And here's where my sternal notch is. I'm gonna go ahead and do 4 millimeter thickness at, let's do user defined or a 0 gap. So that means I'm going to need a lot more slices, ain't I? Okay, so I'm going to go, I'm at the hard palate, I'm to the sternal notch. I like my field of view. I have a field of view of 160 by 160. Right off the bat, I have to think, do I want my phase to go A to P or right to left? And I really want my phase to go A to P. But I'll have to turn on fold over because I'm going to have a little bit of the lips and the tip of the chin wrapping in. So I need to turn that on, and fold over is turned on. Can turn my slices back on here. So I need this to be T2 weighted. My voxel size is 0.9 at 1.1. If you want to bring that 0.9 to 0.9. I'm going to go to my contrast. Right off the bat, I'm going to need to turn on fat suppression. So here is a fat suppression tab, and I can go ahead to spare. In my inversion delay, I'm going to just type in 200 to get me started. My spare TR is 377, so a third of that's going to be what? 120? There we go. Brings in my spare TR, brings it. So if you would do a 110 to 120, you'll be good. Okay? Now, my TE I have as 80. I have a range of 250 by 4500, but I'm going to change that to 6000. And notice then what that did is it allowed my packages to go down to 2 packages, and my actual TR now is 5,457. TE of 80, that would work. If you feel like I want a little bit more signal, you can do 100, but let's keep it at 80, only because think about it. I'm already taking fat out of my image. So I'm taking the fat signal out. So I might need the TE to be a little bit lower on this T2 weighted fat sac, okay? So I have it at 6 minutes and 11 seconds, and it's at 4 necks. So you can go ahead and bring it maybe down to 3 necks. That's a 4.5 minute scan. But always think too that if you really wanted to keep this at 4 necks, you could go back to, this is a sense coil, and I could actually, oh, it is a sense coil, but it's telling me I have to bring it back to my neurovascular coil here. There we go. So you can always go back to your sense, and to bring your time down, you can utilize your sense coil and put in a P reduction factor of like 1.5. Brings it down to 4 minutes. So I've left my motion at 4, and I've utilized sense. Now, how you guys set this up with turning on sense or bringing your necks down, that's your call. I just want you to understand that by this point in the 2 years of parameters here, this is what you do day in and day out by manipulating your parameters. Now, you're going to get in clinic, and sometimes they're going to have things set and you don't change things. And that's okay. You know, they've maximized these images the way they like them. But always remember that when you are on your own, and if you're scanning something and you notice that, you know what, I think I can make this picture prettier, go for it. You know how to change parameters to do that. So, you know, there's many things that you can utilize within your MRI system that can help you get a better picture by understanding how to manipulate these parameters. Okay, so don't be afraid to do that kind of when you are your own MRI technologist. Understand, I understand in clinic that sometimes you can't because you're the student and they're going to tell you, nope, don't change anything. You know, and when you're in, you know, when you're in that type of a clinical situation, that's what you have to do. But once you are your own technologist, then you have that knowledge and the free reign to go ahead and maybe get a little bit better signal or get a little bit better resolution in your images, you know, if you can, okay? So I have a 4-minute scan. I have it covered from the hard palate to the sternal notch. I know I'm going to go ahead and catch the larynx mass. This is good to go. So I'm going to click proceed and start. Now, this is then basically your only practical that you need to practice in your open labs for the practical next week. So, you know, normally you have 2 different protocols to practice. Really, you only have this one protocol. And what's nice about this is go ahead now and hopefully you have then time to go ahead and practice a C-spine, practice a lumbar spine. You know, pull up, take advantage of when you are in your open labs for those 2 hours or even more if you can. Practice, practice, practice for this comprehensive practical coming up, okay? I'm going to flip through and just point out anatomy here. So we're going to go to viewing, and this particular series is my T2 weighted turbospinacal axial. And if I ask you if this is fat-satted, what would you tell me? Is this a T2 fat sat or is this just a regular? Correct, this is a coronal. Yep, did I say axial? I meant coronal. The axial up here, this is my reference. Thank you, Chelsea. Thanks, that just makes me realize that you're paying attention. So is this a T2 fat sat or a regular T2? No, correct, it is not a fat sat. What I notice in this fat signal is on this T2 weighted that my fat is bright. So very good. But as I page through here, I'm going to point out some anatomy. And right away, we're starting kind of at the posterior aspect. This is my axial reference. So this red line is this image. So I'm starting at the back of the neck. And I'm going to go anterior here. So right off the bat, you can see the trapezius muscles coming down. And then you can kind of even see the large muscle on either side. That's your sternocleidomastoid muscle. And then as I get into the throat here, what I'm kind of trying to point out for you is once you kind of start to get into this area here, okay, you can see that this particular structure here, we're starting to get into the larynx and your vocal cords. So I can see the epiglottis up here, and I notice that my larynx and vocal cords are here. If I, let's see, go probably more back here. So if I go back farther, down lower here is where my thyroid gland is at. And this makes sense because I can see my common carotids coming up, right? And remember in our lecture, we talked about how your common carotids come up right where your thyroid gland is located. Okay, so I'm just kind of wanting to kind of point out this anatomy for you. So as you're looking and paging through these images, you understand where this anatomy is located. As I go back to where my subclavian is at, I notice I have this structure coming down. Well, this is part of your brachial plexus, and it travels alongside that subclavian artery. Okay? You can even see part of it here. You can just, these are, remember the brachial plexus is that webbing of nerves. So sometimes it looks like, you know, when you think about the cauda equina, think about that with the brachial plexus here, where you have this convergence of nerves coming through. Look through here, you can kind of almost see as it goes down into this lower axillary part of the left side. Okay, any questions? One other thing that I was going to point out is in this sagittal of the left side here, this is where we can see these scalene muscles. And they're a little hard to pick out, but if I can window it for you so you can see it a little bit better. Notice that there is a muscle here and a muscle here. And as you page through these, you're going to see your little nerves coming between the two. And that is your anterior scalene and your middle scalene muscles. Here is your sternocleidomastoid muscle. As you're paging through these also, look at the little lymph nodes. You can see these little circles. You can see them better when, let me see if I can blow them up for you. Trying to make it darker for you. I don't know if you can see. It is hard to see on these computers, but you can see little lymph nodes in here. And as I page through these, I can even see where this epiglottis and where that hyoid bone's located right there. Okay? And this is more of a center slice because you can see I'm in the center of my spinal canal. Let me put that back here so it's not moving on you. But if I page to the sides, you can kind of almost see here where part of the larynx is at and your vocal cords. Okay. Any questions on anything? What do you guys think? Not too bad? Good, 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 good. Okay, again, anatomy, anatomy, anatomy. I cannot stress that enough. Shalika, what question do you have?
I'm sorry, I said no, I didn't have a question, but I do. So when we take our practical next week, what is it going to be? Are we only doing this sheet, or will it be split up? So will
Nope,
you have two options or just one?
just this sheet. So
Okay.
that
So
is,
okay.
yep, that is the only thing you need to practice. That is why this gives you time to practice other things while you are in lab. And don't forget to get on the MR, that scan lab, and practice that as well. Because again, I think many of you could use some extra credit in the lab grade. So, practice, practice, practice. So when you start taking the tests in on the 28th there, I think, no, the 18th, keep taking them, taking them, taking them. I'm going to be looking at all of those scores, and, hopefully then you guys will do well, and I will give you extra credit for your lab grade. Okay, well, I am going to let you go, and you guys have a great rest of the week. And we will see some of you in lab today. Thanks, guys. Take care.